Buenas tardes, bienvenidos a la gran sesión de NEAS, el grupo de neurovirus emergentes en las Américas. Esta tarde tendremos la oportunidad de escuchar al profesor Arun Venkatesan, quien nos va a dar una charla sobre encefalitis, los conceptos actuales para diagnóstico y manejo. Con este preámbulo, quiero darle la bienvenida al doctor Arun Venkatesan. El doctor Venkatesan es profesor de neurología en la División de Neuroinmunología y Enfermedades Neuroinfecciosas de la Escuela de Medicina de la Universidad de Johns Hopkins. El doctor Venkatesan es un líder en el área de investigación de encefalitis y ha encabezado los grupos multidisciplinarios y sobre todo el consenso alrededor del mundo acerca del manejo diagnóstico de la encefalitis. Dr. Venkatesan, welcome to the NEAS Grand Round. Thank you so much for having time for sharing your experience about encephalitis. We really appreciate your participation.
Muchas gracias, Carlos. It's really a pleasure to be here. Thanks for the invitation. So let me go ahead and share my screen. And I will be talking today about acute encephalitis. And from what I understand, this is quite a diverse audience and a diverse group. And so we'll go through a number of aspects of encephalitis. I should tell you that there's so much that we could talk about, but we only have an hour. And so we will focus mostly on diagnosis and just touch a little bit on management. So here's the outline of the talk. So first, because we have a diverse group, just to make sure we're all on the same page, we'll make sure we understand what condition we're talking about and how it presents, that is encephalitis. We'll then turn to thinking about the differential diagnosis of encephalitis because it's quite broad. And as clinicians, we need to be well versed with all of the other conditions that can mimic encephalitis. We'll talk a little bit about the epidemiology of encephalitis, both infections and autoimmune conditions. And then because the diagnosis of autoimmune encephalitis is such a challenging one, we'll spend just a little bit of time talking about that before we then close with a number of cases that are really going to highlight many different causes of encephalitis, and in particular will focus you on the role of neuroimaging in the diagnosis of encephalitis. Okay, so encephalitis, as I think most of you know, refers to inflammation of the substance or the parenchyma of the brain. And that inflammation can be focal, sometimes it can be multifocal, and sometimes it can be diffuse, right? There can be many patterns of inflammation. The other aspect is that it may not just be confined to the brain substance itself, right? It may also affect the meninges, in which case we call that a meningoencephalitis. Sometimes it'll affect the spinal cord as well as the brain. We call that an encephalomyelitis. And so you might ask, well, how do we make the diagnosis of encephalitis? In classic cases of encephalitis, if we were to get a piece of brain tissue from somebody with, say, an acute infection of the brain, we might see some of these things. We might see blood vessels that are decorated with lymphocytes. This is perivascular cuffing. We might see accumulations of microglia called microglial nodules. Or we might see neurons, which you can barely see here because they're being eaten up by these phagocytic cells. This is neuronophagia. When you do a biopsy in a patient who has an acute nervous system problem and you see this combination of things, well, you can be pretty certain that you're dealing with acute encephalitis. But how do we make the diagnosis from a clinical standpoint? A number of clinical criteria have been proposed in the past. This is one set of criteria that we put forth a few years back as part of the International Encephalitis Consortium. Most of these criteria require a change in mental status, a pretty substantial change in mental status that's not just transient, but that lasts for at least some amount of time, usually at least 24 hours. In addition, there are other supportive criteria that increase the chance that you're dealing with a patient with encephalitis, right? If there's a fever, for example, if there are new seizures or new onset focal neurological findings. And then, of course, if there are laboratory criteria that suggest that there's inflammation, an increase in the CSF white blood cell count, or neuroimaging abnormalities, for example, that show enhancement that would be suggestive of acute brain inflammation. So these criteria are fine, and they work reasonably well when one is thinking about infectious encephalitis. So for example, herpes simplex encephalitis, West Nile encephalitis, other infectious causes of encephalitis. Most of those cases are going to be captured by criteria such as this. And so as a clinician, you can use these to direct your attention as to whether the patient has encephalitis. But what we've recognized is that autoimmune causes of encephalitis can be quite different. And the main difference is that they can be much more subtle. And so what do I mean by that? So this was a set of criteria that was developed a few years back, really focusing on autoimmune encephalitis because the presentation is typically different. And so one of the main differences is right here. So in terms of the alteration in mental status, the autoimmune encephalitides can be much more subacute. They don't have to develop over hours or a day or two. They can develop over days to weeks. That's number one. Second, the nature of the change in mental status can be more subtle than it is in infections, where in infections it's usually pretty obvious that somebody is having major changes to the brain. But in autoimmune conditions, it may be simply a loss of short-term memory or a change in personality that initially may be the clinical manifestation of the encephalitis. In addition, the degree of inflammation may actually be more subtle as well. And you can see that, in some cases, you may not actually have a pleocytosis in the CSF. You may not have an increase in the white blood cells when you do a lumbar puncture. You may just have elevated protein and other laboratory confirmation that there's some inflammation taking place. And so I think you can see that the diagnosis of autoimmune encephalitis can be much more challenging than infectious encephalitis. And we'll talk a little bit more about that as we move forward in the talk. So now that we've defined encephalitis and have some clinical criteria to distinguish patients with autoimmune and infectious encephalitis, let's think a little bit about the differential diagnosis, because a patient doesn't come to you in the emergency room or on the wards or in the street telling you that they have encephalitis, right? They come to you with a relatively acute or subacute change in their neurologic function, perhaps with some of these other signs and symptoms that we just talked about. So here's an example. Here's a 51-year-old male. He has a history of sarcoidosis in his lungs, and he's being treated with immunosuppressants, with mycophenolate. And he's been doing fine in terms of his sarcoidosis. It seems to be in relative control. But he develops a fever and some upper respiratory symptoms and a headache over a few days, and then develops lethargy. He's less interactive, and then aphasia. And he comes in for evaluation, and a head CT perhaps shows some abnormalities in his temporal lobe, and certainly on brain MRI, I think you can see that there's an abnormality here, particularly in the left temporal lobe, perhaps involving a little bit of the right temporal lobe as well. There's no enhancement, meaning the blood-brain barrier seems to be relatively intact. He undergoes a lumbar puncture, and his protein is a little bit elevated. He does not have an increase in his white blood cell count. So the question is, what is this? And we'll come back to what this patient has. Now, in terms of the number of things that can cause encephalitis, it's really vast, okay? So when we talk about infections, the most common causes are viruses, and those viruses can either be sporadic, like herpes simplex virus, the most common sporadic cause, or can occur in epidemic fashion, such as the arthropod-borne viruses, which of course many of you are very familiar with. Really, just about every viral family that has been identified has at some point been associated with encephalitis. The list just goes on. And then one also has to consider other microbial causes, bacteria, parasites, fungi, etc. So a really broad range of infectious pathogens can cause encephalitis. In addition, there's a growing number of autoimmune causes. So many of you are familiar with the anti-neural antibodies that have been associated now with encephalitis, many of which are causative. So we have antibodies that we've identified that can recognize neuronal proteins that are on their cell surface, for example. The anti-NMDA receptor antibodies are the prototypical ones, right? But there's just a growing list of these. And these antibodies can modulate the neuronal function and can result in inflammation and changes in neural function. But there are many other autoimmune conditions that also can result in brain inflammation. Systemic diseases like sarcoidosis, for example, can be associated with brain inflammation, right? There are many other categories as well. So we have infection, a broad range of infections. We have a broad range of autoimmune conditions. But in addition, we have to think about all of the other conditions that can mimic an encephalitis. And really, the range here is quite broad as well. Many vascular conditions can. Now, the nice thing about the vascular conditions is many of them can be ruled out if you have access to urgent neuroimaging, right? But some of the metabolic derangements, right, neuroimaging may not be all that helpful for things like hepatic changes or hypoglycemia, sepsis, or mitochondrial changes. Toxins can acute toxicities can mimic encephalitis sometimes. Patients can come in non-convulsive status epilepticus, and that can mimic an encephalitis. They may have a fever associated with that as well. And so you can see that as a clinician, you have to be very exhaustive when you have a patient who comes in with suspected encephalitis. So let's come back to this patient that I mentioned at the beginning. So the patient had really a pretty broad workup for serum and CSF in terms of infections and autoimmunity. All of that was unremarkable. Appropriately, the patient had been started on acyclovir. When we talk about management of suspected encephalitis, acyclovir is one of the best tools that we have, right? Because it's relatively non-toxic and it works reasonably well against herpes simplex virus, the most common sporadic cause of encephalitis, and has activity against other herpes viruses as well. So the patient was appropriately started on this, but once it became pretty clear that an infection wasn't in the picture, the acyclovir was stopped. And the thought was that the patient had an autoimmune encephalitis. So the patient was treated with steroids, right? One of our really first order treatments for autoimmune encephalitis. And the patient improved. And so this really seemed to add to this notion, this idea that the patient had an autoimmune encephalitis. However, when the patient came to see us a few months later in clinic, we noticed that the patient had some hearing loss. And we then sent the patient for further evaluation because we weren't convinced that this patient had an encephalitis. And indeed, the patient had a cardiomyopathy. And the combination of these changes, the clinical presentation, the lack of inflammation in the spinal fluid, and some of these associated clinical manifestations made us very suspicious for a mitochondrial process. And indeed, the patient had elevated blood lactate, elevated CSF lactate, and we diagnosed him with a mitochondrial encephalopathy. So this is a nice example of a patient who's initially thought to have an encephalitis, but actually has something completely different. Okay, and this is becoming more and more common because the degree of suspicion that clinicians have for autoimmune encephalitis is becoming very, very high, and patients are being mistakenly diagnosed with autoimmune encephalitis. Okay, so that's just a cautionary note. Let's go ahead and turn to the next aspect of the talk. We're going to now really focus on infections and autoimmunity, and we're going to describe the epidemiology of encephalitis. So what's known about the relative contributions of infections and autoimmune conditions to encephalitis? It turns out that there haven't been that many large-scale population-based studies. This was a small population-based study in which quite rigorous criteria were applied to identify patients with either infections or autoimmunity. This was out of Rochester, Minnesota in the United States. And what was found is that essentially the cases, the incidence of infectious encephalitis was very similar to the incidence of autoimmune encephalitis. And so we're recognizing now that autoimmune encephalitis is actually quite common, particularly in the US and in many other places as well, compared to infections. We tried to estimate the incidence of a number of these causes of encephalitis a couple of years back, and this was what we came up with. So far and away, the most common cause of encephalitis worldwide is Japanese encephalitis virus. It's one of these arthropod-borne viruses. It's mosquito-borne. Now, it is largely confined to Asia, and so we don't see much of this here except in travelers who are returning. But as you can see, the incidence is quite high, despite it being, quite geographically restricted. When we talk about other parts of the world, really herpes simplex virus is the most common cause of encephalitis, of infectious encephalitis worldwide. And varicella zoster virus is about half as common as herpes simplex virus 1. Okay. And then when we think about autoimmune causes, look at this. Anti-NMDA receptor encephalitis is probably close to as common as herpes simplex virus encephalitis. Anti-LGI1 encephalitis was initially thought to be about half as common as anti-NMDA receptor encephalitis, but more recent estimates actually suggest that we've been underdiagnosing this condition. This is another quite common cause of autoimmune encephalitis that we need to think about in our patient populations. In the United States, we see West Nile virus quite often. This is the arthropod-borne virus that's most common here, and you can see its incidence relative to that of herpes simplex virus. It's about a quarter to a half as common as herpes simplex virus. Okay, so that was just a little bit about the epidemiology of infectious and autoimmune encephalitis. Now, let's turn our microscope now to thinking a little bit more about autoimmune encephalitis. This is a tough challenge, I think, for all of us. There have been some recent proposed mechanisms by which to diagnose autoimmune encephalitis. This was a consensus paper that came out last year in JNNP. And the idea is that, first of all, like we mentioned, there are supportive laboratory criteria that suggest that there's inflammation, right? So neuroimaging can suggest inflammation, and the EEG can suggest certain patterns that might be suggestive of brain inflammation, okay? And sometimes more advanced neuroimaging, PET scanning of the brain, can actually be helpful. Of course, a lumbar puncture is really critical. And in the diagnosis of an autoimmune encephalitis, the presence of CSF neuronal autoantibodies is key, right? And typically we'll test both the CSF and the blood for these antibodies. There is some value in testing for both. The CSF in general tends to be more specific, but there are certain autoantibody-associated disorders where the serum testing is actually more sensitive. And so we typically will send for both. And then because autoimmune encephalitis is sometimes driven by cancers, we'll often screen for malignancy in patients who come in with suspected autoimmune encephalitis with CT scans and mammograms and ultrasounds as appropriate. Okay. So let's see how this schema plays out in the real world. Okay, I'll show you a case here. So this is a case of a 28-year-old gentleman who was eventually referred to us. He was a software engineer living in California. He lived in a wooded region, but really didn't get outside much, had no known animal exposures, no foreign travel recently at least, who developed some headache and some mild confusion and saw his primary physician, was given Augmentin for what was thought to be a sinus infection. Soon after that, he developed a lot of agitation and then delusions. He felt that he was a character in the show Game of Thrones, which some of you may be familiar with. And this was actually quite concerning to him because he was being attacked and there were people scheming against him. He developed low-grade fevers and came to the emergency room where he did have a mild increase in his peripheral white blood cells. He underwent a head CT that was unremarkable. And because of these changes in his neurologic status and his fevers, the thought was, well, could he have encephalitis? So he underwent a lumbar puncture, and you can see that the protein was, borderline. But look at this. He certainly has an increase in his white blood cells in his CSF. They're mostly lymphocytes, as you can see here. And so this seemed to suggest that there is some acute brain inflammation here, and appropriately he was started on antimicrobials. He was started on ceftriaxone as an antibiotic and started on acyclovir for the possibility of herpes simplex encephalitis. His blood and CSF cultures were negative, as were the CSF viral PCRs. So these were sent for herpes simplex virus and varicella zoster, in addition to several other viruses. All of these viral PCRs were negative. Soon after that, he was noted to have a marked increase in his blood pressure and his heart rate. Okay. He underwent some additional testing. His EEG was unremarkable. He wasn't having seizures. That wasn't the cause of this increase in blood pressure and heart rate. He underwent a brain MRI. That too was unremarkable. He underwent a repeat lumbar puncture. Okay. And the repeat lumbar puncture showed 37 white blood cells. So he still is having some inflammation, right? There's some persistent inflammation there. He underwent a repeat CSF infectious workup. And this was, and an autoimmune workup, and it was quite broad. And you can see some of the testing that was done here. Okay. He then underwent additional serum testing. And finally, one test turned up positive. This was an anti-TPO. This is one of the thyroid antigens to which he has antibodies against. And this turned out to be positive. So he also underwent some malignancy testing, and this was unremarkable. So he was diagnosed, I'll tell you in a second. So in terms of this schematic of autoimmune encephalitis, so what criteria does he fulfill here? Well, the brain MRI was normal, okay, so he doesn't really fulfill that criteria. His EEG was normal, right, doesn't fulfill that criteria. Certainly there's evidence in his spinal fluid of inflammation, okay, and so that suggests that there's something either infectious or autoimmune here. His lumbar puncture did not demonstrate antineuronal antibodies, but his serum testing showed some antibodies, not the classic antineuronal antibodies, but these antibodies against thyroid antigens. And then the screening for neoplasm was unremarkable as well. So does he fit this criteria for autoimmune encephalitis? He was diagnosed with this condition, Hashimoto's encephalopathy, which is an autoimmune condition that affects the nervous system. And he was treated with steroids and IVIG, and he got better, okay? His aggression, his paranoia, all of this gradually improved, such that by a month later, he was at baseline. He was at baseline for a year, went back to working at this high-level, software job, and then again developed increasing headaches, agitation, paranoia, delusions. Has a repeat lumbar puncture, again, marked pleocytosis here, right? So he's got inflammation there, and this time his CSF anti-NMDA receptor antibodies come back positive. And when we think back to his initial presentation, I think many of you are now familiar with this, most common cause of autoantibody-associated encephalitis called NMDA receptor encephalitis, where there can be a bit of an infectious prodrome, but very shortly thereafter, there can be pretty dramatic psychiatric changes. And that's indeed what happened. And then dysautonomia is actually quite common in the setting of anti-NMDA receptor encephalitis. And I think that explains his marked increase in the heart rate and the blood pressure. So this patient indeed had an autoimmune encephalitis, but I think you can see that really didn't fulfill that criteria initially, did he? So there are many complexities associated with autoimmune encephalitis. An infectious prodrome can occur and often leads us to thinking about an infectious encephalitis when the patient actually has likely an infection that triggered an autoimmune process. Psychiatric symptoms are very common, particularly in NMDA receptor encephalitis. I've shown you some of them here. Importantly, the brain MRI can be unremarkable, and it often is unremarkable. Multiple antibodies can be present, and this can be confusing. And in this case, the patient had these anti-thyroid antibodies that were probably just a red herring. They probably didn't really suggest the actual diagnosis in this case. Relapses can occur, and they can actually occur sometimes years later. And in very rare cases, the causative antibody is not found on initial testing, and one needs to do repeat testing in order to identify that autoantibody. Okay. So we've walked through the definition of encephalitis. We've thought about the differential diagnosis. We've talked about the epidemiology, and I've mentioned to you and illustrated to you some of the complexities in diagnosis of autoimmune encephalitis. So we're going to move on to some cases that illustrate various causes of encephalitis and that show you the role of neuroimaging. I see a question here in the chat before we move on. Why does the lumbar puncture go after the imaging and not before? I think, Maria, that you're probably talking about this schematic that was put forward in this recent consensus paper where, there's a brain MRI, there's an EEG, there's a lumbar puncture. And, I think that what's really being shown is that there are multiple types of testing that are being done. There's a type of testing that's being done to really look at whether there are focal brain abnormalities, and with that, you can use an MRI and an EEG and sometimes a PET scan. There's the type of testing that shows you what's happening in the fluid in the central nervous system, and that's the lumbar puncture, or in the fluid in the body, and that's either lumbar puncture or taking of blood. And then there's the type of testing that's directed to determining whether there's a malignancy, and there's all those scans that one can do. So I don't think it's necessarily suggesting an order here. It's just breaking things down in terms of the types of testing. So thank you for that question. Okay, so let's go ahead and get to some cases, all right? So here's an interesting one. Here's a 44-year-old woman, previously healthy, very high-level banker, who was admitted with a week of intermittent fever, confusion, and speech difficulties and poor memory in Germany. She presented to the emergency room on the day of admission with several generalized tonic-clonic seizures. So here's her exposure history. She had recently traveled to Germany. That's where she had this illness, but lives in Taiwan. Really nothing else substantial in terms of exposure. She resides in an urban area, and she underwent at the emergency room here in Germany a head CT scan that was unremarkable, and they felt that her general exam also was unremarkable. But what was remarkable was her neurologic exam. You can see here that orientation, attention, calculation, recall, all of these were extremely impaired, and her mini mental status score was a 16 out of 30. This is very, very low for those of you who are familiar with this scale. In somebody who had a chronic score of 16, you would consider them demented. But otherwise, her neurologic exam was unremarkable. She didn't have any focal weakness. She didn't have any other sensory changes on exam. Okay. In terms of other testing, her serum sodium was a little bit low at 122. She underwent a lumbar puncture, and you can see here that there is a pleocytosis. She has 14 white blood cells in the CSF. PCRs for a number of viruses was negative, as were some serologies for some other infectious etiologies. And her initial brain MRI was unremarkable, but her EEG did show some abnormalities in the left temporal lobe. So anyone who comes in with suspected encephalitis, really you should be thinking about herpes simplex encephalitis, and in particular, if there are brain MRI changes or EEG changes in the temporal lobe, you have to be thinking about herpes simplex encephalitis. And indeed, that's what they thought about, and they started the patient on acyclovir and also on an anti-epileptic agent. Over the next few days, she developed some focal seizures, and her brain MRI changed. This is what it showed a few days later. This is a coronal brain MRI, and I think what you can appreciate is these areas of hyperintensity. These are brighter, and you can see them in the temporal lobes here, the mesial or middle parts of the temporal lobes, and in some other areas here as well, the cingulate and the insula, for those of you who are familiar with the neuroanatomy. She underwent a repeat lumbar puncture, and it showed 7 white blood cells and evidence of what we call intrathecal antibody synthesis. She's making antibodies in the central nervous system that are not present in the serum. So really suggestive, again, of some kind of infectious or autoimmune process in the nervous system. So the question is, what does she have here, right? She has an encephalitis. She has these temporal lobe abnormalities. Does she have herpes simplex encephalitis, or does she have some other condition that mimics herpes simplex encephalitis? So we looked a few years ago with some colleagues at cases of encephalitis that involve the temporal lobe to try to figure out what's the range of causes here and can we come up with any clues as to what might be causing them. And so you shouldn't be surprised to see that herpes simplex virus is the most common cause of temporal lobe encephalitis. And then you see some other infections as well. Tuberculosis can do this, varicella zoster as well, along with a number of non-infectious or autoimmune causes. Okay. When we look a little bit more closely to see, can we distinguish between herpes simplex and autoimmune cases? When we look at the lumbar puncture, actually the white blood cell counts can be fairly similar, especially early on in herpes simplex encephalitis compared to autoimmune cases. Well, you might say, well, what about the red blood cell count? Because, the classic teaching is that herpes simplex encephalitis is associated with lots of red blood cells. It's a necrotic process. Well, it turns out we didn't see any difference in the red blood cells either. We'll come back to that in a minute. What about imaging characteristics? Are there any imaging characteristics that can distinguish between the two? And it turns out there are, okay? So the MRI that I showed you is actually not very typical of herpes simplex encephalitis. In the case that I showed you, there are very symmetric bilateral temporal lobe lesions. That's much more consistent with an autoimmune cause. And it turns out that herpes simplex encephalitis, it's usually much more asymmetric. Okay, and in addition, if you have lesions outside of the classic kind of limbic areas, that again suggests an autoimmune cause. So there are some imaging characteristics that can really help you distinguish between a herpes simplex encephalitis and an autoimmune encephalitis. You'll see that hemorrhage also does not distinguish between herpes simplex and autoimmune causes. Why is this the case? Why are we not seeing hemorrhage in the cases of herpes simplex encephalitis? I think it's because we have gotten better as a field at diagnosing this condition earlier and at doing these studies earlier, the MRI and the lumbar puncture. And early on in herpes simplex encephalitis, you don't see evidence of hemorrhage. So I think this is an important take-home point that a patient with encephalitis, even if you don't see hemorrhage, you still have to consider herpes simplex as a cause. All right, so let's return to our case. So this patient's MRI was much more consistent with an autoimmune cause of encephalitis. Look how symmetric these temporal lobe lesions are. So a big workup for autoimmunity was done and for neoplasms as well. And it turns out that this patient was found to have very high titer antibodies to GAD65, one of these neuronal antibodies, and was diagnosed with anti-GAD65 associated limbic encephalitis, was treated with steroids and IVIG and really got better quite quickly and was able to return to her job as this banker back in Taiwan. Okay, so I think I've shown you now, some of the differences in imaging between herpes simplex encephalitis and these classic autoimmune limbic encephalitides. All right, let's turn to a very different case. All right, this is a 9-year-old girl in India with fever, progressive headache for a few days, then seizures, low platelets on admission, and this is what her MRI showed. And I think you can see that there, rather than changes in the temporal lobes, as we saw in the prior case, here we're seeing changes in the deep gray matter. So this right here is your basal ganglia, here's your thalamus, okay? And so you're seeing changes that are very deep in the brain. So what could be the cause of encephalitis here? So we again looked at a number of cases of encephalitis. And what we found is that if we looked at the cases that had deep gray matter abnormalities in the thalamus or the basal ganglia, as compared to all the other cases of encephalitis, there were really two types of etiologies that were overrepresented in these thalamic basal ganglia lesion encephalitis cases. One was respiratory viruses, and then two was West Nile virus. And West Nile and other arthropod-borne viruses are actually quite recognized as having a predilection for affecting the deep gray matter. It turns out that there are some characteristics that distinguish between these etiologies as well. And so, for example, the arthropod-borne viruses like West Nile often will result in thalamic involvement, and usually bilateral thalamic involvement. The respiratory viruses are associated with thalamic and basal ganglia involvement, as you can see. And so, one can get some additional clues if you look at the specific pattern of neuroimaging here. Coming back to this girl, so she ended up having not only these abnormalities that you can see on brain MRI that I showed you initially, but also some evidence of hemorrhage and necrosis actually in the deep gray matter. And she ended up having a dengue virus encephalitis, something that I think many of you are quite familiar with. And I think you can see how imaging can help you in terms of its diagnosis. Okay, so that was a case of deep gray matter encephalitis. All right. Now here's a very different case. Let me tell you about this patient. So this is a 31-year-old male who was doing pretty well, at least in the recent few months. But one day prior to admission, his fiancée noted that he was very apathetic. He didn't seem to care much about anything, and he was quite confused and unable to recognize his daughter. On the day of admission, he had a fever, and so she brought him in. His history is interesting. So he does have diabetes. It was relatively poorly controlled, and about 4 months before this presentation, he was found to have a liver abscess, this strep species, that in people who don't have diabetes, this is really just kind of a commensal organism. But in diabetics or others who are immunocompromised, it can cause disease. So he was treated with penicillin for 3 months and was thought to have cleared that infection. No other sick contacts, no recent procedures. On admission, he was febrile and mildly tachycardic and a little bit hypotensive. He was oriented only to himself and had marked difficulty expressing himself in terms of language, was very slow, very abulic. He was incontinent of urine. And this is what his head CT showed. And I think what you can see is that there are some abnormalities here in the frontal lobe. These are hypodensities bilaterally in the frontal lobe. So he underwent some serum testing for infections. This was all unremarkable. He underwent a lumbar puncture, and it showed a mild pleocytosis. He's got 10 white blood cells in his CSF. He's got some inflammation there, right? So the question is, what's the cause of this? And, the clinicians, in trying to put together the clinical picture, said, okay, well, he's a diabetic. He had this recent abscess. He's got these abnormalities that are, multifocal in the brain. Perhaps this is brain abscess, right? And he was started on broad spectrum antibiotics for that. But he worsened actually very quickly and was transferred to us. So we did some additional workup, right? And we were concerned about infection as well, but his blood cultures were all unremarkable. Certainly he had an elevated sedimentation rate, some evidence of systemic inflammation. We did a repeat spinal fluid analysis, again, had 10 to 15 white blood cells. We were concerned about this prior liver abscess that he had. And so we did this broad, CT scanning, and that was really unremarkable. The prior liver abscess was gone. We were concerned about endocarditis, did a transesophageal echocardiogram, and that was unremarkable. But here's what his brain MRI showed. This was really remarkable and actually quite distinctive. So on this side, I'm showing you what's called a T2 MRI, and on this side is the T1 after gadolinium. So this is a contrast MRI scan. And so you can see, first of all, that in the frontal lobe, lots of lesions that are multifocal. And on after giving gadolinium, you can see that most of these lesions, if not all of them, enhance. That is, there's breakdown of the blood-brain barrier around these regions. And in fact, there's kind of a distinctive shape associated with this enhancement pattern. And so we thought, based on this, we were pretty confident that, we knew what was happening. But because of his history of diabetes and this liver abscess, we wanted to make sure we weren't missing an infection. And he had this right frontal lesion that is in a relatively non-eloquent area. And so we ended up having him undergo a brain biopsy. And this is what the brain biopsy showed. Okay, so here's the H&E staining, and you can see lots of inflammatory cells in the brain. This is very unusual, right? The brain is relatively immune privileged, and so there's not that much normal immune cell trafficking that occurs in the brain. We did 2 other stains here, and I'll tell you what these are. So first stain is called Luxol Fast Blue, and this is looking for myelin. And what you can see here is in a normal brain, this should be very blue. The white matter of the brain will stain blue here. the myelin stains blue. And you can see here that there's a little bit of blue, but most of the blue is gone. So there's not much myelin here in the brain. But what you can see in this neurofilament stain is that the neurons and axons are very well preserved. You can see this nice brown staining. So there's relative preservation of neurons and axons, but a lot of demyelination, right? And so this patient indeed had an acute demyelinating condition, acute disseminated encephalomyelitis. This is typically a multifocal process of inflammation. There's often an infectious prodrome that is then followed by the neurological manifestations. It's usually a monophasic or one-time event, and sometimes we can identify an infection. Sometimes there's a vaccine that's administered before this that might trigger it, and often it's just a spontaneous event that we're not able to see. Okay, so that is ADEM, and you can see that that has quite a distinctive imaging pattern associated with it. Let's take a look at another interesting imaging pattern. So this is a 2-year-old boy, all right? Develops fever and a rash and multiple visits to an outside hospital, is thought to have some kind of a bacterial infection, was given amoxicillin, but about a week after the onset of his symptoms, he develops respiratory distress, and then very shortly thereafter, decreased level of consciousness and develops a generalized tonic-clonic seizure. So on admission, he's febrile, he's tachycardic, and he's not very responsive, and he's intubated for mental status to protect his airways. He does have normal cranial nerves, but he's got some extensor posturing. So this suggests really wide diffuse central nervous system dysfunction. This is what the rash looks like. I think you can see this kind of petechial rash that's on his torso here and on his extremities. His peripheral white blood cell count is very high, as you can see here, 36,000. His lactate is quite high as well. He's got a mild elevation in his transaminases. His head CT shows maybe some subtle edema. It's not really clear. And his EEG shows bilaterally that there's some irritability and abnormality. Okay. Now, a lumbar puncture is attempted, and unfortunately, it's extremely bloody. And so he has lots of white blood cells, but this is really not interpretable because it was a markedly traumatic tap, and it didn't clear with multiple accessions of his spinal fluid. But this is what his MRI showed, and this is really a remarkable pattern. Again, very different from what I've shown you, very different from herpes simplex encephalitis, very different from an autoimmune limbic encephalitis, very different from dengue or West Nile, right? Very different from ADEM. Here you can see that there's so this is the T2, and this is diffusion-weighted imaging. This is the ADC, for those of you who are familiar with some of these sequences. But the bottom line is he's got multiple tiny little punctate abnormalities that are relatively deep in the subcortical white matter. And you can see they're scattered both anteriorly and posteriorly, and they're on both sides of the brain. And you can see that there's some restricted diffusion associated with this, suggesting really that there's a diffuse vascular problem here associated with the inflammation. And indeed, this patient ended up having very high titers of IgM antibodies to Rickettsia rickettsii. And that was the diagnosis, Rocky Mountain spotted fever. It turns out there are many, many rickettsial species that can cause CNS infections, and the geographic distribution is really worldwide, right? And you can see here there are some that are kind of endemic to Africa, some that are in the Americas, some that are in Europe. Orientia susugamushi is increasingly recognized, this is scrub typhus, increasingly recognized as a re-emerging cause of encephalitis and meningoencephalitis in Asia, particularly in India. And so as clinicians who are faced with patients with suspected encephalitis, we need to be aware of these rickettsial species. Many of them have systemic manifestations, like I described. There can be DIC-like manifestations where there are problems with coagulopathy and consumption of coagulation factors. There can be decreases in platelets. And often there's evidence of an associated vasculopathy that one can see either on imaging or sometimes on ophthalmologic evaluation. Okay, so we're going to come now to, I think, what's the last case that I wanted to show you. So this is a 68-year-old. Oh, and I should mention the neuroimaging pattern here is really, really distinctive. There aren't that many other causes of acute encephalitis that can do this, and it's so distinctive that it's been given a name. This is called the starry sky pattern, and particularly in children who have rickettsial infections, they will develop this starry sky appearance on neuroimaging. All right. So let's turn now to this case. This is an interesting one. So this is a 68-year-old male, very healthy, very active, who developed, what looked like kind of a typical pneumonia in July 2019 by his family physician. Initially treated with amoxicillin, and then with another antibiotic, moxifloxacin. But the antibiotic treatment didn't really seem to help initially, and follow-up imaging of his lungs showed a lobar pneumonia, and shortly thereafter he developed some headaches. A few weeks later, he presented to the emergency room because of really significant headache and a mild change in his alertness. He was becoming more lethargic. His head CT scan was unremarkable, but his lumbar puncture shows evidence of inflammation, right? 24 white blood cells. This time, most of the white blood cells are polymorphonuclear cells, right? Unlike all of the other cases that I've mentioned to you where we've seen lymphocytes. So the other cases that I've shown you associated with viral or autoimmune causes are typically going to be associated with lymphocytic pleocytosis. This one wasn't. His protein's elevated, but the glucose and the lactate are normal. By day 8, he's got a marked coma. His Glasgow coma scale is 5, and this is what his brain MRI shows. This is different than all of the other cases that I've shown you. This is his post-gadolinium scan, and you can see lots of small enhancing lesions that are scattered throughout the brain, both peripherally and more centrally. All right, so he's got multiple ring enhancing lesions, and these lesions are complete circles of rings as compared to the ADEM case that I showed you, where there are lots of C-shaped patterns of ring enhancement. So again, this is quite different. So he underwent a pretty extensive workup. Initial CSF studies were negative. His HIV testing was negative. He didn't have syphilis. He was tested for toxoplasmosis. He had a pretty big rheumatologic evaluation that was unremarkable. And he had scanning. This is now a few weeks after the initial pneumonia. And it actually looked like the pneumonia had resolved, and there was nothing else concerning on CT scanning. So he's got multiple ring-enhancing lesions. And as neurologists, when we see this in the brain, there are a number of things that we think about. We think about tumors like a CNS lymphoma. We think about granulomatous infections like tuberculosis or other fungal infections. We think about demyelinating diseases as well, right? So what does this individual have? Well, it turns out that there was a lot of diagnostic uncertainty, and so he actually underwent a brain biopsy. And this is what his brain biopsy showed right here. So this is a silver stain of one of these lesions, and I think you can see multiple kind of filamentous organisms here on silver stain. And you might be saying, well, this seems to be consistent with a fungal infection, but actually I've put this image side by side with a classic fungal infection. And so here's an Aspergillus infection of the brain. And what you can see here is a much thicker, larger hyphae, right, than what you can see in this patient. And so this patient actually turns out not to have a fungal infection of the brain, but has nocardiosis. And so you may be familiar with the idea that there are several bacteria that can actually mimic fungal infections. So nocardial species and actinomyces are really the classic ones. They can mimic them in the clinical presentation. They can mimic them on neuroimaging. And interestingly, sometimes the laboratory pathologists can get fooled as well, because as you can see, these bacteria can have these filamentous structures that are initially sometimes thought to be fungal infections. And of course, if you treat them with antifungals, you're not going to do them any service, and you're going to subject them to the side effects of these antifungals, and they're going to get worse because you're not treating the infection. So this patient found to have nocardia, treated with long-term antibacterials, and recovered quite nicely. All right, So I'm going to stop there. We've covered actually quite a lot of ground in terms of infectious and autoimmune encephalitis. We started out by defining encephalitis. We considered the differential diagnosis of encephalitis, the broad range of infections and autoimmune causes, in addition to the large number of other acute neurological conditions that can mimic encephalitis. We talked about the epidemiology of encephalitis in terms of infections and autoimmunity, and how in many parts of the world, the incidence of recognized autoimmune encephalitis is approaching that of infectious encephalitis. We talked about the challenges of diagnosing autoimmune encephalitis and how we need to really keep an open mind when it comes to this diagnosis, and we need to try to bring all of the tools that we can to bear to diagnose autoimmune encephalitis. And then we talked about the role of neuroimaging and how it can help in distinguishing not only infectious from autoimmune encephalitis, but also in identifying or cluing us in as to certain categories of infectious causes. So I'm going to stop there and see if folks have any questions.
Arun, thank you very much. That was a beautiful, very comprehensive review of encephalitis, and we really appreciate that. So I'm going to outline my question in English, and I will translate that a little bit to Spanish. But I need to emphasize that at least in Latin American countries, Colombia, Venezuela, Ecuador, Peru, we deal with a lot of infections, particularly tuberculosis and viral infections. So one thing that actually caught my attention from your presentation is the emphasis in autoimmune encephalitis. So what I'd like to get your opinion is, what is the likelihood that some of the viral infections and what is the likelihood of some of the infectious disorders that produce encephalitis later may produce an autoimmune encephalitis? And give me 30 seconds to translate that. Una de las preguntas importantes es el énfasis en enfermedades autoinmunes que producen encefalitis, pero la pregunta que estoy haciendo es, ¿qué tan frecuentes algunas enfermedades infecciosas pueden inducir enfermedades autoinmunes que son encefalitis autoinmunes? Y ese es uno de los temas interesantes que estamos explorando con el grupo NEAS en Colombia particularmente. So Arun, what is your opinion?
Yeah, really nice question, Carlos. So, I think it's clearly become recognized that infections can trigger autoimmunity, and in particular, there are some infectious causes of encephalitis that can trigger autoimmune encephalitis. And I imagine that many of you in the audience are familiar with the story that herpes simplex encephalitis can be followed by an autoimmune encephalitis, that it can trigger an autoimmune encephalitis. And what can happen is patients can have a very typical herpes simplex encephalitis. They can be treated appropriately, but weeks to months later may develop either a recurrence of symptoms or new neurologic symptoms. And when those patients are evaluated, it turns out that they have new inflammation and they have autoantibodies associated against neuronal antigens. This may happen up to a fifth of the time, which seems astounding, right? I think it's probably a little bit less than that, but nevertheless, this is not an uncommon occurrence. And it's not just herpes simplex encephalitis that can do this, but many other infections now have been associated with a post-infectious autoimmune encephalitis. So it's one of the reasons I wanted to emphasize autoimmune processes here because of that link. The other reason I wanted to emphasize it is I think that there are cases that are being mistakenly diagnosed as infectious encephalitis because often, we are relying on serologies to make the diagnosis. And often we're relying on IgG serologies, for example, to make the diagnosis of, say, arthropod-borne infections. And I think that in some of those cases, well, maybe they have that arthropod illness that's driving the encephalitis. But in some of those cases, the presence of elevated IgG may simply reflect a previous infection. And it may be that they actually have an autoimmune encephalitis, and that if one were to investigate further, one would actually find evidence for that. So I think that, surely, I think in many, for much of the audience, infections are going to be a more common cause of encephalitis than autoimmunity. But I'm guessing that we are underdiagnosing autoimmune conditions, not only in North America, but in Central and South America as well.
Thank you, Arun. Dr. Dominguez?
So we have a question from Dr. Vargas. He's one of the site investigators of the NEAS study. So he's talking about his recent experience. In the last 2 weeks, they've had 7 patients which have had as a first manifestation of tuberculosis, confusion, and cranial nerve involvement. How frequent is that as
Yeah.
in CNS TB?
That's a great question, and I think we see this, and so cranial nerve involvement is actually I think not that uncommon with tuberculosis, as I think you guys know, it does tend to affect the base of the brain, and the cranial nerves are exiting from that area, and so it certainly happens. I think it's remarkable that you've had 7 patients in 2 weeks. That is really amazing, and raises the question of whether if these are all in the same area, of whether there's some specificity to this strain of mycobacterial TB that is causing it to really layer along the base of the brain. But certainly this has been recognized. That's a really interesting observation.
So el doctor Hernán Bayona, uno de nuestros colegas neurólogos en Cali, pregunta cuál es la mejor evaluación para encefalitis autoinmunes. Ustedes usan el test panel. So this question is in reference to autoimmune encephalitis. Dr. Bayona is one of our colleagues in neurology in Cali. So he's asking about what is the best workup for autoimmune encephalitis and what is the test panel. And actually, for clarifying that question as well is, remember that in Colombia, we have a lot of difficulties for sending this type of panels, so because we don't have access, as we do here, to the Mayo Clinic labs. And if we do, are extremely expensive, by the way.
Yeah. No, it's a great question. And this is a challenge, I think, that, when resources are a little bit limited, it becomes much more difficult to test for these autoimmune conditions. There is a company called Euroimmune, which, sometimes does subsidize, slides that one can use to try to identify autoantibodies. It's, probably not quite as good as, the Mayo panel or some of the other panels that have been developed, but it's a reasonable approach. And so, for those of you who don't have, other options, exploring this idea of this Euroimmune panel might be helpful.
Thank you so much, Dr. Venkatesan. We have another question from Dr. Beatriz Gonzalez, and she's asking if you could expand more about Coxsackie virus, its epidemiology and role in infectious encephalitis.
Yeah, great question. So I had it listed in that table of causes of encephalitis, but it turns out it's, as I think most of you know, it's much more commonly a cause of meningitis. And in fact, it's that group of viruses and related viruses are probably the most common cause of meningitis. It causes an aseptic meningitis, meaning, patients present with what looks like an acute meningitis syndrome, but the Gram stain is negative, you don't identify bacteria, and it's actually, the virus that is the cause of meningitis. Sometimes there is some associated encephalitis with that. So I would say that when we talk about Coxsackie-associated encephalitis, most of those cases are going to be meningoencephalitis. It's a very good question.
Thank you so much.
So Arun, this is again a very important question, particularly for Latin America, Central America, and South America. Is we don't have MRIs on the first hand in the majority of hospitals in our countries. We don't have the opportunity to go and do an assessment of PCR in many hospitals. So I was struck by your approach at the beginning that you said patients that develop very quick, rapid progression of symptoms very likely have a viral encephalitis as compared with other patients that develop symptoms over 2 weeks or 3 weeks that very likely are autoimmune encephalitis. Do you mind expanding a little bit and see how in countries with very low resources, we can at least tackle the question between infection versus
this is
autoimmunity?
Carlos, it's such an important question. And, one of the reasons I wanted to share these MRIs is because I understand that, but I think it's important that the audience is exposed to this and sees, the utility of neuroimaging so that, you can advocate for some of this testing and advocate for getting some of this testing because you see how important it is. But surely, in places where there is not that kind of access, one has to rely on clinical criteria. And I think that it's something we're very interested in. So we have been studying this in collaboration with Rodrigo Hasbun, who's in Texas. And so we've actually just looked at a large number of patients with infectious and autoimmune encephalitis, and we are developing a way that clinically we can try to suggest whether one has an infection or autoimmunity. And so certainly one of the key characteristics really is the time course of presentation. And that's where being a really good physician and a good clinician makes all the difference, right? Because if you can get a really good history and you can understand the time course of illness, boy, that can really help you in terms of stratifying whether someone more likely has an infection or an autoimmune condition. There are some other parameters as well. Infections are typically associated with more inflammation and behavioral changes like psychosis and other things are more associated. We will probably be soon, and I think it'll be helpful to people who may not have, all of the resources. Well, these were great questions. Thank you all so much for the engagement and for the opportunity. I don't know if there are any other questions.
There are a couple of questions, Susana.
Yeah, so we have a question of Dr. Enrique Hernandez. How frequent herpes zoster presents as encephalitis? They've had 3 cases in 4 months in his hospital.
That is an excellent question. And the epidemiology of this is changing. At least in North America, we're seeing this now much more in immunocompromised individuals, people that we are treating with immune suppressants who are developing herpes zoster and associated central nervous system problems. And so I think I can't give you a specific figure as to the incidence of encephalitis because of that changing epidemiology. But I think you're absolutely right that we have to think about VZV as a cause of encephalitis. I showed you in that table that it's probably the second most common infectious cause of encephalitis in many countries, and I think it's probably under-recognized. Actually, it's a very strange virus in that certainly treatment is very helpful, getting acyclovir on board, but it's one of these viruses that can kind of cause disease and that can resolve. It can almost in some cases cause a relapsing and remitting disorder and can actually sometimes improve even without dedicated antiviral treatment. And so I think it can get missed. So I thank you for casting attention on VZV encephalitis.
Thank you so much.
We have 2 more questions, and I will basically condense 2 questions in one. And this is in the follow-up of these patients, you have seen relationship between encephalitis and mental disease like schizophrenia, obsessive compulsive disorder, or bipolar disorder, and that should be actually complemented. Is when is the need to check the panel of antibodies for autoimmune encephalitis? Is that most productive in blood or in CSF or both?
Yeah, yeah. So most of the time, the CSF is better than the blood. Like I mentioned, there are a few cases where the blood testing is really needed. But if you really had to put your money on one sample to send for autoimmune testing, it would be the spinal fluid. Um, in terms of these psychiatric manifestations, I guess I should mention two things. So first of all, so psychiatric manifestations are very common as presenting signs and symptoms of some of the autoimmune encephalitides, but in almost all cases, within days to a week or two, additional neurological manifestations arise. And so, somebody who develops an acute psychosis and that's it, right? And they don't develop other neurologic symptoms, they don't develop dysautonomia, it's very unlikely that it's an autoimmune encephalitis. It's much more likely that they have a psychiatric condition. That was their first onset of psychosis due to, say, schizophrenia. And so I think that nowadays many people are getting very worried that they're missing autoimmune encephalitis as a cause of acute psychosis. But I would say that if no other symptoms develop, then you're fine. You're not dealing with an autoimmune encephalitis. Okay. And then the corollary to that question that you asked is, can encephalitis result in some of these psychiatric symptoms or syndromes? And, just like any neurologic injury, depending on the aspect of the brain that's been affected and that's been damaged, one can have a wide range of, cognitive or behavioral changes. And sometimes those behavioral changes can mimic a psychiatric condition like schizophrenia or OCD. It just really depends on the specific brain area that's affected. And we certainly wouldn't label those patients as having schizophrenia or OCD if they've had damage to the brain that preceded, the psychiatric manifestations.
Susanna, can you read the last question?
So the last question is about dengue. Could the encephalitis caused by dengue be described due to the tropism of this flavivirus towards the brain, regarding the case you presented?
Yeah, really good question. And so there's certainly mounting evidence that a number of these flaviviruses, do have some capacity for neurotropism, and that likely explains the deep gray matter involvement in, say, Japanese encephalitis and in West Nile encephalitis, and perhaps in dengue as well. I think it's not quite as well understood, but I think that's a very reasonable hypothesis.
So Arun, thank you very much for your participation. It is great to have you here in our meeting and in our group. And your information about encephalitis was quite amazing. And thank you very much. I hope that we can invite you again next year so you can give us updates about your work and your research.
That would be wonderful.